is Guardian Radio, your station for up-to-the-minute news and intelligent, interactive, and engaging conversations. 96.9 FM. The views and opinions of the hosts and guests are their own and do not necessarily reflect the views of the management and staff of Guardian Radio.
With early detection comes early prevention. Put lead in your pencil, make you feel like a champion. Rise up again, let nothing keep you down. To live your best, hear the urologist speak. Oh yeah. Think you're losing grip of your manhood, don't give up on hope. Don't be ashamed, it's time to take control. Get some help from the urologist. You will find he'll help you solve your problems on 96.9. Yeah. I telling you, with early detection comes early prevention. Put lead in your
Good evening, Bahamas. This is Urologist Speaks with Bahamian Urologist Dr. Greggory Pinto. We have a very interesting show as always. We're trying to be inspirational and trying to stress the positivity in our society. Right now, it's my honor to have a friend and colleague, Dr. Vanterio Taylor, who is a general surgeon and a Canadian-trained transplant surgeon. He's made the news recently in having heading the team that did the first renal transplant successfully at Princess Margaret Hospital. So he's here to speak about that. We're going to talk extensively about the plague of renal failure in our society and how all the non-communicable diseases that is overwhelming our medical system and our society is resulting in far too many people on dialysis. So it's wonderful to have the best dialysis units in the world, best dialysis nurses. It's wonderful to have this transplant team going and transplants in the future. But let's try and be proactive. Let's prevent people in the next generation, this current generation, from going down the path of unnecessarily going into renal failure. So we're going to talk about renal failure as well. So tell us a little bit about yourself, Dr. Vanterio Taylor, and welcome again.
Thank you for having me, Dr. Pinto. It's a pleasure to be here. So a little bit about myself. I was born in Freeport. I grew up in Nassau. My people are from Mastic Point, Andros. And I've been to the government high school, as you may know. It's my alma mater, and I'm proud of it. At the time that I was there, the science program was the strongest in the country, thanks to your father, Mr. Alan Pinto. I give him a shout out. From there, I attended the College of the Bahamas, and from there, the University of the West Indies, both in Jamaica and here in Nassau. I did my medical degree at the University of the West Indies and my surgical residency. And as you noted, I did a transplant fellowship in Calgary, Alberta.
So you're basically a son of the soil.
Son of the soil.
And you came from humble beginnings. You're a wonderful, positive product of our government high school.
Yes, I am.
So there's not enough emphasis, particularly in the media, on the radio, on the television, in regards to positivity. Particularly, we're going to talk about, and I always try to do that, young men are not doing enough. There's a generation of men that are lost and wayward and not going anywhere, and crime is on the rise. And unfortunately, the vast majority of crimes are committed by our young men in our society. So I hope just having you here is going to inspire somebody who doesn't want to pick up a book, that doesn't see a future or any success in academics, and you're here to show that there is a way. It wasn't a difficult road. And just on a personal note, we were 20 years ago in the trenches as senior house officers.
Yeah.
And there's no worse existence than that. They say diamonds are made with pressure, but it's almost like we were cotton pickers on the plantation. So you develop a bond where we're on call together. They're sometimes 24 hours seeing the worst of humanity, gunshot wounds, stab wounds, running into theater in the trauma room. So you develop a very close friendship and be able to rely on somebody because you, along with that team on call, basically has someone's life in their hands. And the stress is overwhelming. So only someone who's gone through that stress and the stress of residency, I mean, we can just talk on and on. There's no greater hell on earth than the stress of going through residency, actually having to train, to study, to operate, to be on call, and then to pass exams that are basically created to make you fail. And to come out on the other end is a great success. And then coming back home, the real hardship starts. There's a lot of obstacles put on in your way. There's a lot of haterism. We'll talk about that. There's a lot of black crab syndrome. Even, I'm sure, as you've had some amount of fame and fortune and success from doing this renal transplant, there's way too much negativity pointed at you or anyone else who's doing anything positive in the society. The average Bahamian, and it's a crying shame, will be happy to see a transplant team come in from North Carolina or Miami, and all foreigners do the transplant. They'll get all their rave reviews and applaud and everything else, and then leave. And someone who is grew up here, family grew up here, went through our own high schools, went through Princess Margaret Hospital on every level, from student to intern to senior house officer to registrar to senior registrar to consultant, now senior consultant. They don't want to see our own succeed, and that's a crying shame, and it doesn't something that we need to change as a society. So, in terms of kidney transplant, obviously there are many reasons for someone going into renal failure, but let's both agree we need to obviously get this renal transplant going. And I had to rotate through renal transplant just as any urologist would do. But I know what difficulty is and the amount of precision it requires in terms of surgical expertise to put off renal transplant. And I give you your kudos for that. But what we're trying to do is prevent people from going on dialysis. What can you talk to people in terms of how do we prevent the society as a whole from continuing to have higher and higher numbers of persons on dialysis?
Well, people go on dialysis because their kidneys fail. And kidneys fail for a number of reasons. But the most common reasons are preventable. When I say preventable, I'm talking about end-stage disease from long-standing diabetes that's not controlled properly, long-standing hypertension that's not controlled properly, maybe drugs that are taken without the advice or without the supervision of a physician. Those are three major reasons why people go into preventable renal failure.
And everything you mentioned, we have one of the highest incidents, not only in the Caribbean, but in the world.
Yes.
And it's not just recognizing that someone has hypertension. We also have to look at the mentality of the typical Bahamian patient in terms of being compliant with their medication and accepting their diagnosis.
Nobody wants to claim the disease.
Not at all.
Everybody says, I don't have that. No, the doctor says I have it, but I don't have it.
And don't put that on me.
Yeah.
And their blood pressure will be sky high on numerous readings over numerous days. And no. That's white coat syndrome. No, I had some extra salt in my eggs this morning. Or I ran up the stairs trying to get here. Every excuse in the world, but everybody's heard this. High blood pressure is a silent killer.
Yeah.
And you're not going to have any symptoms whatsoever. Diabetes is also a silent killer. Mm-hmm. Imagine how many people who have diabetes and hypertension, it's slowly killing them from the inside out. Yeah. The first organ to go for men is going to be their male organ, where their erections are going to fail. And then it's eventually going to go to their kidneys. It's going to affect their eyesight. It's going to affect their heart. And there's a strong correlation between renal health, the function of the kidneys, and actually cardiovascular health, the function of the kidney. Yeah. And the heart go hand in hand. 20% of the blood flow that pumps from our heart goes into the kidneys. Yeah. So if you're going to have failure of your kidneys, it's also many of the same predisposing conditions are also going to negatively affect your heart, and that's going to basically reduce the longevity of your life, and it's also going to reduce the quality of your life. So let's talk about someone who goes into renal failure and requires dialysis. Let's scare some people and talk to them about the living hell of getting AV fistulas or possibly doing peritoneal dialysis. Persons who never want to get a needle stick, having to go in and out, their AV fistula failing, waking up 3 times a week, 4 o'clock in the morning to go in and get dialysis. Let's talk about the life of someone who, first of all, is diagnosed with renal failure and what they have to go through.
Well, the kidneys are responsible for managing the fluid in the body. It's responsible for managing the acid and base in the body. It's responsible for managing the blood pressure. So when the kidneys fail, you fill up with fluid. Fluid fills up the lungs. Fluid fills up the legs. Fluid fills up everywhere that's dependent. Your blood pressure becomes sky high. Your blood counts become low, and everything, all of the salts become out of balance. And so when that starts to happen, kidney disease goes from being silent to being overt and in your face. And it goes on for so long until you have to come into hospital because of the symptoms of shortness of breath, because of chest pain, because of leg swelling, because of itching. All of these things happen, and if it's not looked at and taken care of, it forces you into hospital.
And then you have the GI, gastrointestinal, like you said, nausea, vomiting, poor appetite.
Everything just popped down.
You can get a GI bleed. It's a horrible cascade of negative events that it doesn't happen in one day.
No, but when you do come into hospital, it's expected that we try to fix it as soon as possible. But even with that mandate to try and deal with it as soon as possible, that means emergency dialysis. Now, for your listeners, dialysis means taking the blood, taking some fluid, putting a filter between them, and allowing exchange to occur. The way that most people think of dialysis is hemodialysis or blood dialysis, where you sit in a chair 4 hours at a time, 3 times a week, and you're connected to the machine, and the blood goes from you to the machine. It filters through, and it's returned to you. There's also another type of dialysis called peritoneal dialysis, where we put a tube or a catheter in the abdomen, and we fill the abdominal cavity with fluid, and that fluid sits there and exchanges with the blood vessels in the abdomen, and then we drain the fluid and do it over and over again. When somebody comes in an emergency, hemodialysis is what we need to do. Peritoneal dialysis, you have to set up something in advance. You have to set up a time to put in a catheter, and it takes a while for that abdominal surgery to heal. But for hemodialysis, it can be done emergently, but that means putting in an emergency catheter. That means an emergency catheter
Which
in
is
the groin.
Yes, it's not going through your urethra. This is not a urethral catheter. Yes,
but it goes
vascular catheter.
It's a catheter that goes through in the veins of the thigh. That's done at the bedside, mostly under local anesthesia, meaning you don't put to sleep. But it is an emergency and it needs to be done, and so we do it. And then after you get that short-term catheter that goes in the thigh, you get hopefully dialyzed a few times, and hopefully the toxins are cleared and you start to feel a little better. But you're in hospital and you can't go home with that temporary catheter. So now we need to make preparations for more longer-term access. And so we try to plan for a catheter that's held under the skin, so it's more permanent, it's less likely to get infected, less likely to get dislodged, and that's done in the operating room. As most people know, operating time in the Princess Margaret Hospital is a premium, and it's very difficult to get as everybody operated on in a timely fashion. And so there's a bit of a wait for anybody that has a short-term catheter to get a long-term catheter. That said, you get your dialysis with the short-term catheter until you get the long-term catheter, and then after you get the long-term catheter and it works well, the hope is that you can go home.
Okay, so when we're looking at monitoring for renal failure, obviously you don't want to wait until there's symptoms. So everybody needs to get an annual physical. And
Yes.
bloods, routine bloods, looking at your creatinine level, your BUN. So creatinine is not creatinine that you take when we're trying to
Bulk up.
Bulk up, yeah, exercising. You also want to know your glomerular filtration rate, your GFR. It's also important to know whether you have any protein in the urine, which is protein urea. So it is normal to have a small amount of protein, but especially when you're getting rid of the fluids, the toxins, etc., all the harmful substances, you want to retain your protein. You're going to have a small amount of protein in your urine, that's normal. But if you have excess protein or protein is being pooled into urine, that's one of the early signs of renal failure. So previously it was very cumbersome. We had to do a 24-hour urine collection. You asked a male or a female to actually urinate into a jug over a period of 24 hours. But now we have spot urine, and you get a value called a urine albumin creatinine ratio, which is called ACR. So this is a measurement of how much protein is excreted in the urine. This is also important because the ACR value also plays a role in terms of cardiac failure, in terms of heart failure. So the more protein you see spilling in the urine, the greater the chance you have in renal failure. So let's talk about the importance of being preemptive, of being trying to preempt this from happening. How do we stop dozens and dozens? Do you have any idea in terms of numbers of persons right now on dialysis in our nation?
Well, the government is covering about 600 people on hemodialysis at the moment. Just to put that in perspective, in the U.S., the amount of people on dialysis as an average is about 700 per million. And so we have a population of approximately 400,000, and we almost have that amount already.
And that doesn't even include the private patients, which is...
It includes, it's a little bit of overlap, but not all.
Okay.
So that's just the amount that government covers, not the people that have private insurance, just the amount that government covers, because they cover just about everyone that's at PMH, and they cover some of them are outsourced to private facilities as well.
And what's the estimated cost for annual dialysis for one patient?
Well, it's difficult to put that number down. I can say that it's been estimated that over the past year, the PHA has spent about $15 million in total for dialysis-related costs.
And much of that, most of those patients are preventable cases, correct?
Most are hypertension, diabetes, and could have been prevented or managed. Yes, most of them are.
And it's a crying shame. We have persons even in their 20s who unfortunately are on dialysis. I mean, some people are adult or bad end because of genetics, familial diseases. Some people have polycystic kidneys, and inevitably they're going to end up in renal failure. There are those who may have lupus nephritis may end up on dialysis, or Alport syndrome, or Fabry disease. These are all rare conditions, but for the most part, the vast majority of these persons are on dialysis.
Hypertension and diabetes.
Only have themselves to blame. And in many cases, they still continue to not take care of their health. They still have this whole concept of being just absolutely irresponsible.
I like to believe that those people are in the minority. I like to believe that.
I would wish that to be the case.
I think that's the case.
I see patients in dialysis all the time, every other day, and we check their blood pressure. Anyone who comes in the office, they get their vitals taken. Their blood pressure is sky high. Do I have to even look into their history? Why are you on dialysis? Oh, because I had high blood pressure and I never took my medication. So I'll say to them, why are you not taking your blood pressure medications now? Oh, well, it's too late anyway, so I'm already on dialysis. They can't do any more harm to me. That's their level of understanding. They still have their eyes functioning. They don't realize they can end up with a stroke and have half their body not functioning and live the rest of their life in either a bed or a wheelchair. They understand they can end up in having a heart attack, a myocardial infarction. Just drop down. The lack of understanding, that's why I'm here, and I'm glad you're here as well, and Dr. Wesley Francis, who comes when he's available. We're trying to, knowledge is key. If you understand what can happen, what is the danger of not doing certain things, maybe that fear, and we're trying to put some fear in some people because they don't want to listen.
You got to affect change.
Yeah. I mean, obviously, bush medicine has a role, but you can't just, if your blood pressure is sky high, you're already in renal failure. You don't stop your medication and say, my grandma say,
Take this
bush medicine and I'm fine. And you never even go and check your blood pressure.
Yeah.
Or, I'm going to cut out salt and I'll be fine. Or I lost 5 pounds. You're living in ignorance. So you need to understand. We talked a little bit about what causes renal failure. That's important. So basically, we can look into obstructive, non-obstructive causes. You can look at pre-renal, intrarenal, and post-renal causes. Well, I won't bore you, but we'll talk about pre-renal causes. You look at what might reduce your blood supply or blood volume to your kidneys. That could be from dehydration. That could be from hemorrhage, from trauma. That could be from excess fluid loss from vomiting or diarrhea. You can have decreased cardiac output. 20% of your cardiac output goes to your kidneys. You can have heart failure, or you can have cardiogenic shock, which are numerous reasons for that. You can have impaired renal failure secondary to certain medications like NSAIDs. There are too many Bahamians who pop NSAID medication like it's candy, and they don't know the harmful effects of that.
Those medications should be prescribed. They should be taken under the advice of a physician. You get people who get their hands on Motrin or Voltaren, or it's their friends or their relatives' prescription, and they just have a pain, chronic pain, for example, knee pain, back pain, and they take as many as they want to for as long as they want to, and then by the time they make it to the doctor, the kidneys are popped down, are shot.
Yes, so if you have knee pain, first of all, you always determine what the root cause. If you have knee pain, have it investigated. You don't take Voltaren twice a day for 6 straight years, and then you find out you're in renal failure, and on top of everything else, you're then ending up on dialysis. Then we talk about intrarenal causes. The most common form of renal failure is actually called ATN, acute tubular necrosis. And this is damage to the kidney tubular ducts, and this is usually secondary to ischemia, a lack of blood flow to the kidney, or to nephrotoxins, which include certain medication. Another intrarenal cause is glomerular nephritis, which is inflammation of the glomeruli of the kidneys, which are essentially the filtering units of the kidney. Again, this can impair the kidney function. You can have acute interstitial nephritis. You can have vascular disease. You can have, again, nephrotoxic drugs. You can have post-renal causes, which I often see as a urologist. Obstructive causes, whether it's a urethral stricture, preventing you from emptying your bladder, or it can be urinary tract obstruction secondary to enlarged prostate, whether it's benign disease, BPH, benign prostate hyperplasia, or prostate cancer. You can have numerous tumors within your urethra, within your ureter, in your kidney itself, within the bladder itself. You can have a neurogenic bladder. There's a high number of incidence of neurogenic bladders in the society. A lot of it is related to uncontrolled diabetes, where you have diabetic cystopathy. So there's so many ways that we can be afflicted by renal failure. But the most important thing is, if you're getting your annual physicals, all these silent things are not going to just creep up on you. And it doesn't, in most cases, happen in weeks, months, but it happens over several years. So there's no excuse. We have NHI. You can, no insurance, no funds. You can spend 45 minutes of your life for once a year to dedicate to your health and your longevity and your happiness, and make sure that you don't become a burden to your family. If you don't like seeing a doctor, imagine what dialysis does. All you do is see surgeons and doctors
over
in the emergency room, in dialysis unit, praying for a renal transplant, getting an AV fistula that fails, going in to get repaired, getting infections. It's a horrible existence. So please use that as a motivation. I always use it as a urologist. Men, if you want to keep your erections, keep yourself in the best possible health. That means getting your annual physicals, taking medications if you have to take it, and living a healthy life. That means exercise 2-3 times a week. That means watching what you eat, maintaining a normal body mass index, et cetera, et cetera. Everybody knows what they should and shouldn't be doing. And then it's a crying shame that not enough people listen to us or listen to their physician, et cetera. So let's talk about the types of renal transplants. So a a lot of persons are not aware that you can actually have deceased donors. You can have cadaver. So when I was doing transplant, the vast majority of the cases that we did were cadavers. So they were from persons who were deceased.
Yeah, so in my training also, most of the transplants that we did were from deceased donors. So in my training, we got the call that, hey, there's a potential donor who's brain dead, and they're going through the legal framework. The hospital is talking to the family and getting all of the paperwork signed so that they can become a donor. In the jurisdiction that I trained in Canada, they had an opportunity to identify themselves as donors before death. And so when somebody was identified as a donor and did meet an untimely demise by brain death, the ball was rolling in terms of getting them sorted out, getting them tested to find out if they were suitable to become a donor. In the Bahamas, we have living donation, and that's all we have for now. For deceased donation to become a reality, we need to pass some legislation. I had a hand in writing a draft of that legislation that hopefully should be brought before the Parliament before the end of the year, I'm told, that allows for us to define brain death and to allow for procurement of organs in patients that are brain dead, and to set the framework and to set the guidelines and to set the laws in place so that everything is done above board, everything is done with I guess, sense and sensibility.
And obviously, we're not reinventing the wheel.
No,
this is something that's well established in many countries, even third world countries, for decades and decades. So, it's in terms of determining whether someone is brain dead, it's their protocols that are involved, and they're widely accepted. We also talk about preemptive kidney transplant.
Okay, so
Tell us a little bit about preemptive kidney transplant.
So we talked about, you mentioned the glomerular filtration rate, or GFR. Think of it as having your kidneys operating at 100%. And so the number, we say the GFR is 100 is a normal GFR. And as you go through life, your GFR decreases, it declines. And as your kidney sustains insults or hits, your GFR declines even further. What happens is if you go from 100 to 75 to 50 to 60, when you reach close to 30 to less than 30 to less than 20, those are the numbers that you're going to need dialysis at. Anything less than 20, you need to be considered for dialysis. Anything less than 10, you're most likely on dialysis or almost on dialysis. What we try to do is that when you're doing your physicals and you're following up and you're watching your GFR, if we're able to keep it up as high as possible for as long as possible. But even in some instances, it does drop to the point that you may need dialysis soon. And it's best that we get our dialysis access placed before you need it. If you don't have it done before you need it, you come into hospital as an admission, pop down, feeling shortness of breath, chest pain, leg swelling, itching, decreased appetite, all of that stuff. If you get an access before you need it, instead of having a lengthy admission like we talked about with a short-term catheter, then and then wait for a long-term catheter, you can head straight to your nephrologist, and then they can send you right to the dialysis unit to start dialysis instead of a lengthy admission. If you make plans, you can have a soft landing into dialysis instead of a crash landing that most people have.
Well, also when we talk about legislation, the places I've trained in the world, it's very straightforward because on your driver's license, part of the documentation in terms of getting a driver's license, are you willing to be a donor? So the persons who come in, catastrophic car accidents, they're deemed to be brain dead. They're not going to recover. And they can live, part of them can live on, and their family can take solace. And you know what? You can donate part of your liver, part of your kidney. I've been part of penile transplants. Your corneas. That can be living. You can have 12 different persons living on for decades with part of your loved one inside them, allowing them to have a better quality of life.
Deceased donation is a beautiful thing. It's a silver lining in the tragedy that befalls various young people. There is provision in the proposed legislation for either the national insurance card or the driver's license, whatever national identification card that we're using, to be used as the marker or identifier to identify those people who wish to become organ donors. So when that legislation is proposed, when it's passed, there will be a registry. You'll have the opportunity to identify yourself as a deceased donor.
So it's essentially the gift of life in a time of an untimely death. And there's some positivity that can come out of a tragedy, as you said.
Yes, so you'll have the opportunity to. It's not that anybody's going to take your organs without your consent or without your permission.
And it's not as if we're taking you off the
life support.
The life support event.
This speaks to only people who are already dead.
Exactly that. And they're only mechanically still
being kept alive by machines.
Exactly that. So I think that there'll be great solace. Obviously, no one wants to think about death or tragedy, but if you can have your organs live on in others, whether you're giving
you can save at
gift
least
of eyesight or your kidneys or your heart or your lungs or your liver to someone else, or even your skin for someone who's
even your tissue or your bone.
Or your tissue or your bone, exactly. We'll talk more about this interesting topic on the other end of the break. This is Urologist Speaks.
Give away a cruise. Guardian Media Group and Going Places Travel wants to take you on a 7-day cruise for 4 to Panama, Colombia, Curacao, and Aruba on Royal Caribbean Serenade of the Seas. And here's the best part. No visa required. That's right, no visa required. You have 4 ways to enter, 4 ways to win. Number 1, fill out the form in the NASA Guardian. Number 2, listen to Star 106.5 and Guardian Radio 96.9. Number 3, follow us on Facebook and Instagram. Number 4, or make a purchase at any Going Places Travel. Entry deadline is June 27th, 2025. Drawing will be taking place on July 4th, 2025. So you know what that means? Pack your bags and get ready to soak up the sun and feel the ocean breeze. You and 3 loved ones sailing the high seas on a vacation cruise of a lifetime. Brought to you by the Guardian Media Group and Going Places Travel. Certain conditions apply. Airfare, taxes, and gratuities not included.
You try to rest, roll with the best. For all your printing needs, there ain't no one better, no. For posters and banners, magazines and flyers, for window decals, greeting cards and newsletters. No job too big and there's no job too small. You name it, we can print it, just give us a call. Let Print Masters bring your masterpiece to life.
Located in the Nassau Guardian Building, telephone 302-2361.
Always on the go? Missed a show? You can now listen to Guardian Radio talk shows anytime, anywhere on Spotify and YouTube by searching Guardian Radio 96.9 FM or by entering the name of your favorite show. You can also listen by logging on to GuardianTalkRadio.com and clicking on the podcast. Guardian Radio, continuing to provide you with fresh news and smart talk anywhere, anytime, all day.
Love the show? Want to give your support? Become a sponsor today. Call 302-2300 for our rates and packages. That's 302-2300. Become a sponsor on Guardian Radio 96.9 FM. Fresh news, smart talk, all day.
This is Guardian Radio 96.9 FM. Fresh news, smart talk, all day.
Welcome back. This is Urologist Speaks with Bahamian urologist Dr. Greggory Pinto. And in the studio, we have Bahamian general surgeon and transplant surgeon Dr. Vantario Taylor. We're speaking about renal transplant, renal failure, trying to scare some persons in our society from becoming a statistic of renal failure and getting on dialysis. So there's a lot of misconceptions in regards to, okay, once you get a renal transplant, all your struggles are over. Let's talk about the immunosuppressive drugs. Let's talk about the failure that can happen in the kidney being rejected, and the fact that for a deceased donor kidney, you may get 12 years, you might get 15 years. Even for a live donor, it might be 15, 20, 25 years. So a 35-year-old who high blood pressure, got renal failure, and got a kidney transplant from a sister, they still may need another kidney transplant in their lifetime. So the struggle isn't over.
That is true.
So let's prevent you from ever becoming one of these statistics who have to live a life of struggle.
Well, kidney transplant is a treatment for kidney failure. It's not a cure. There is not a cure presently for kidney failure. It's the best treatment that we have available. It's a standard of care. Not everybody is eligible for a transplant.
And not everybody is eligible to be a donor as well.
That is true.
It's a very strict protocol. I mean, those who are at risk of losing their kidney for whatever.
So the testing that we do for potential living donors is very rigorous. It's one of the most extensive testing that there is for a patient. It involves testing your heart, testing your lungs to make sure you're fit for surgery. It involves testing you for all sorts of infectious diseases and make sure that you're not transmitting anything with the kidney. It involves making sure that you have all the age-appropriate cancer screening, and it involves looking at the kidney itself to make sure that it looks good and it functions good. When I say look good, meaning the amount of it has one artery, one vein, and one tube connecting it to the bladder. When I say it functions good, we talked about that GFR percentage, making sure that there's enough of a percentage in both kidneys so that you can give a half of your percentage, and the percentage that you're left with is still enough to carry you on to a long, fruitful life. And then there are other things that we look for example, social factors, psychiatric evaluation. All of that is done to make sure that you, as a potential recipient, the donor that you bring, is able to give you the kidney. And that's even before we look at tissue typing and the match. You may have somebody that's willing to match, willing to give you a kidney, but they may not be able to because of incompatibility with either blood group or tissue type. Usually, in those cases, we have to pool together where we can find pairs that may not be able to give you may not be able to give your brother a kidney, but maybe Sammy and Sue up the road, Sammy can give your brother a kidney and you can give your kidney to Sue, that sort of thing, where it's called a pair donation.
And what is life like in general for someone on immunosuppressive drugs? So it's essentially reducing your immunity, the ability to fight infections and diseases.
So receiving a kidney means that you get a kidney that's not yours. The body is set up in such a way that anything that's not of your body, that's put inside your body, your immune system or the cells that fight foreigners, they're activated usually. So if we put in a kidney into somebody without giving specific immune medication, the kidney would be rejected, the kidney would be destroyed. And so anybody that receives a kidney has to take multiple medications, usually 2 or 3 medications for the life of the graft, the life of the kidney, to hide that kidney from the body's immune system so that the immune system doesn't recognize it as foreign and doesn't attack it. But this also means that the immune system is hidden from, maybe it's not able to see bacteria or see viruses or see fungi or other infectious particles as clearly as they usually would. And so being on immunosuppressants means that you're at a slightly increased risk of infections.
And that includes in the age of COVID-19. You're going to be at
Yes.
risk of getting COVID-19
Yes.
and having a worse outcome from COVID-19. And not just
Yeah.
one disease. So it's a lifelong struggle that the average Bahamian does not have to go through. In terms of percentages, you are very well excellent person to answer this. Hypertension, as you say, diabetes, how many of these 600 persons on dialysis right now, or 600 plus, would you say, inevitably, no matter what we did, the best screening in the world, the best healthcare system in the world, would have ended up on dialysis anyway? They just basically had a predisposition because of genetics.
I'd like to believe that it would probably be less than a fifth of those people would end up on dialysis. And I like to believe that the lion's share can be tackled or prevented with primary care.
And imagine living with that regret. I mean, there's so many things you live with in life. One of the most painful things, a lot of these persons who wake up 4 o'clock in the morning for the rest of their life, 3 times a week to get dialysis, which is a grueling ordeal in itself and draining and everything else. The regret that they didn't listen to their physician because they didn't take their high blood pressure medications, or they didn't go for an annual physical for 12, 15 years, or they didn't take care of their health, or they never exercised, or they smoked, et cetera, et cetera. The list is endless.
Now, that said, I do want to say that I like to believe that it's less people that are behaving in that manner than you make it seem. I like to believe that most people would want to take care of themselves, even if it is after getting the news that the kidneys aren't doing as well, that they, from that time forward, they're doing what they're supposed to do.
But as we would both agree, this doesn't happen in one day, it doesn't happen in 1 year. For the vast majority of these persons, it's happened in 5, 8, 10, 12 years of sustained uncontrolled diabetes or hypertension, etc. If they just went to get their annual physical once in that 5 years or 8 years, they would be clued into the fact that this is a major problem that's going to lead to a disaster. Maybe they can curtail what may happen.
Well, sometimes they are able to slow it down. So we talked about that percentage. So if you have a start out of the percentage of 100 and then you make it to your doctor one day and they say, hey, this percentage is 45% now. And that's ringing an alarm bell that, hey, things are not what they should be with the kidney. And many times we're able to slow it down over, for example, instead of the dialysis being needed next year, you may be able to slow it down in the next 6 or 7 years.
And a lot of it has to do with understanding. There are those who, as children or teenagers, remember their grandmother all of a sudden going on dialysis, and the only thing they can remember out of that is, oh, Grammy was diagnosed with diabetes, she started diabetic meds, and 2 months later she ended up on dialysis. So I'll never take diabetic meds in my life. They don't understand the link between the diabetes that your grandmother had for 15 years, ignored the symptoms even when they may manifested themselves, and then by that time had end-stage organ disease, and it was basically too late. Maybe the diabetic meds prevented her from losing her eyesight, maybe prevented her from having a heart attack or a stroke.
But the kidneys were far gone.
The kidneys were far gone. So half our population are men. 110% of Bahamian men, the most important thing is getting their erections on time, whenever they want, in their fullest glory. The motivation to get that to happen is to take care of your health, go for your annual physicals. If you have a non-communicable disorder, such as hypertension, diabetes, hypercholesterolemia, if you're overweight, listen to your physician, listen to your dietitian, listen to your family, because most of them are going to tell you something's going wrong and you're living an unhealthy life. Stop the cigarette smoking, stop the cigarette smoking, stop living every day with fast food, and you will live a fruitful, long life with your erections into your 80s, and that's every man's dream. So that should be the motivation. And the other motivation is you don't want to go in the hospital. You hate seeing a white coat. You hate going to the doctors. You hate a needle stick. 95% of Bahamian men are afraid of a needle stick. That we need to address because many of them, that's the reason they don't go for an annual physical. Let's just talk reality. We can actually give you numbing agent where you don't even feel the needle stick. Some of these nurses are are so astute that you don't even feel that needle stick. So please don't let that fear.
Yes.
Some people are having a vaso attack and they're going to faint. Thinking about it, and when they see the needle, they're going to have a panic attack. So a lot of persons, they don't mind going for annual physical, but the fact that they're so afraid of a needle, and it doesn't have to be painful at all.
No, it doesn't.
The real pain is allowing things to happen where you're going to be stuck like a pincushion
in hospital,
in and out of hospital, wait in the emergency room for 6 hours. That's overwhelmed with trauma and violence. That brings up a topic I always like to a fellow surgeon who's been. We were there 20 years in Princess Margaret Hospital. Let's talk about the amount of upscaling of violence that you're seeing, the amount of resources, supplies, operating theater time, because of the violence and crime in this society, and how it's affected you in terms of doing elective cases. How has it affected you in terms of stress and everything else in your profession?
So violence is a plague upon this small island country. But we don't have the resources to deal with the shootings, the stabbings, even the people that are on the motorcycles that don't wear their helmets, the people that are flying by in the cars without their seatbelts. All of these people, there's only one major public hospital for them to come to. There's nowhere else to go. Once you become injured, once you become an aggressor or a victim of violence, everybody comes to PMH. On a good day, we're full. On a bad day, we're bursting. What we find is that it's very difficult for us to do our elective cases. You have people with gallbladders that need to come out. You have people with hernias that need to be fixed. I'm sure you have people with stents that need to come out and get put back in. When these cases are planned and the corner boy comes in with the gunshot wound or the stab wound, or the guy on the motorcycle falls off and gets a head injury, and they need to be treated emergently, that takes away anesthesia, that takes away an operating room, that takes away medication, that takes away an ICU bed, that takes away so many resources that could be put to somebody who's doing what they're supposed to do and just happens to have a problem that needs to be fixed with elective surgery.
I can't count the number of times over the decades where we would have to put off cancer cases that we can see are progressing before our eyes because a person has a mass, for example, kidney tumor, or has a bladder tumor that, because they have so many other non-communicable disorders and they're at high risk, need an ICU bed, even if it's post-operatively for 1 day or 2 days, and there's never a bed.
Never an ICU bed.
Or even for elective surgery, someone who needs a post-op bed, there are no beds because there are 20 trolleys with patients waiting to get admitted in the emergency room, and the cycle doesn't end.
No.
Someone who's shot may take up an ICU bed for 3 months. I've seen it all the time. Paraplegics, someone who's shot in the spine, they're in and out seeing all the multidisciplinary teams because of this, because of bed sores, because of urosepsis, because of kidney stones, et cetera, and there's no end in sight. And why are we such a violent, angry society? A lot of it has to do with men with bottled up rage and have no outlet for it, and there are no consequences for their actions. It's a revolving justice system.
We need to work on our conflict resolution.
Very much so.
We need to work on an outlet for the young men.
And unfortunately, we bear the brunt of it as surgeons. Obviously, we are expected to perform miracles and save people that shouldn't be saved. And I've seen patients who were saved that maybe in most places in the world they wouldn't, because we have become
so skilled at
trauma. We have seen as much trauma as anyone else, as if we were in the Iraq War, that their miracles are. The murder rate would be a lot higher if it wasn't for the brilliant, dedicated nurses of emergency room and physicians in emergency room and the surgeons and their skill and the blessings that God has given them to pull off miracles. The murder rate would be much higher, and no one wants to look at that. I remember cases where we would be waiting. For example, in urology, you get to operate twice a month. What can you do in twice a month? No. Because there's not enough anesthesia staff, there's not enough operating staff, there's not enough time. Even supplies are in short supply. Equipment is a problem. A lot of cases have to be postponed indefinitely because of equipment issues as well. There's overlap of equipment where, for example, a C-arm where we use fluoroscopy, that might need to be used by an orthopedic team. At the same time, urology team plus the vascular team, and all three are operating at the same time. So essentially,
it's a fight.
Two are sitting on the sideline doing nothing, while someone else is using the one functioning C-arm. So it's a crying shame. Good evening. We have a call coming. This is Urologist Speaks.
Yeah, good evening, Dr. Pinto.
Good evening.
I didn't get the name of the doctor.
Dr. Vantario Taylor.
Yeah, I don't know. I think you said he's a nephritis or nephrologist.
I'm a transplant
kidney
surgeon.
Specialist?
I'm a transplant surgeon and a general surgeon. So.
Oh, yeah, all right. Yeah, the thing is, Dr. Pinto, I was listening, and so I had nightmares for my situation, which was quite unusual because of the size of the prostate, right?
Yes.
And the impediments during the surgery, both surgeries. So, like sometimes it's good to hear things from a patient's perspective. I highly respect you. You know what I've been through, right?
Yes.
So what I'm saying is, I've learned so much, even from encounters with you, Dr. Pinto, and Stevens, Robert Roberts, and all that. And so I always read. I was always a reader, and so in sharing this, right, maybe as juxtaposing this to the conversation that you and the doctors having about, if they live long enough to have a prostate problem, then I guess they would humble themselves, right? But the thing is, as it relates to the kidney problem, what happened is I thought he was a nephrologist, but Dr. Pinto should be able to answer this because I remember during my stay, you would urinate, and then there would be a certain amount of milliliters, and then that will I don't know the parameters which will show the kidney is healthy. So that information would be healthy because even you would urge people listening that they could go and buy one of those urinals, because I remember you telling me specifically that it had to be a certain amount. I didn't educate myself fully on it, but I knew that would prove how healthy the kidneys is. But I also learned just from you, I could look and see if my bladder is full or empty because I'm slim, and I could actually look and see if my bladder is distended. You understand me? And you should be able to do that if you educate the patients, because there's also the concern for me when I initially came into contact with you and other prostate doctors, urologist, I was like, I don't eat meat, and I say I'm safe, I exercise, etc., etc. I don't drink alcohol, maybe a beer here and there, a social drinker like that, right? And I still end up with this BPH, and so I always wanted these external factors. But I thank God that I have friends much younger than I, and Dr. Pinto, you've known some men have died from prostate cancers in their 40s, right?
Very much so.
I've seen it. Even
in the 30s.
I've seen it. So what I'm saying is, someone like me, I could appreciate you, but what I'm saying is the kind of pain and suffering I went through with not so much with some of the nurses were misinformed about prostate conditions. I don't know because we are men, but I was quite vexed and taken aback when they was telling me that, I was still having the urge to urinate whilst being catheterized. You understand me, doctor? You see what I'm saying? I was still having the urge to urinate even though the catheter was in me. And so they would say, oh, you don't need to urinate when the catheter is in, even I've worn both. So what happens was when the catheter became clogged, they couldn't conceive what was going on. That almost cost me my life on the ward one night because they didn't understand that the blood clot, that sometimes post-surgery the doctor would come in and use a syringe and remove the blood clots. I said, praise God for that. Because then the catheter became clogged, and so it was 200 milliliters for a couple of hours, and I knew that can't be because I was drinking a lot of water to avoid blood clots, et cetera, et cetera. So being conscious about the situation, but also as it relates to the prostate cancer. You reminded me now that I haven't done my annual, Dr. Pinto. I really need to go and do that because
Please do.
That's the way. Yeah, that's the way to keep it. You know what I mean? But I see I'm urinating for longer periods of time, et cetera. But you kind of scared me with the kidney problem that can be hard from BPH. So I urge young men to pay attention to it. And so, one more question before I go, as it relates to the biopsy. I heard some innovation. I don't know what show it was, but proton. I'm familiar. I've heard about proton chemotherapy. Radiation for that for the past 10 years. I don't know that was in the States, but I know it'll take light years before it comes here. Because I heard it's very non-invasive, and when we discuss innovations, we never discuss affordability. And so I had asked you about the mRNA test and there's an mRNA test, MRI, etc. Which one of these is good to detect a prostate in the early stages, Dr. Pinto? Because I'm afraid of this one, and diabetes. Just answer the last question. I ain't going to listen.
Okay, thank you for excellent points. So brachytherapy, which is internal radiation, which is an outpatient procedure, which is done minimally invasively. It's an excellent curative treatment for prostate cancer. I've been trying to get it here for the last 8 years, and I do see the light at the end of the tunnel, and I'm sure it's going to happen before the end of this year. Equipment is already in the process of being purchased, and it's going to be widely available, and that's going to transform prostate cancer treatment here, because to tell somebody that they can maintain their erection at a 90-something% rate, really have little to no urinary issues after the prostate treatment, no cut, no stitches, no pain. You can come in 40 minutes, outpatient procedure, go out, go to church the next day, go to work the day after that. That is going to be the definition of minimally invasive with an excellent cure rate, and that can change the landscape and the way Bahamians and residents think of prostate cancer and prostate cancer treatment. So it's very soon coming, and it's always been a dream of mine to bring that here. For many men, and they did a study once looking at urologists and what would they choose if they themselves got prostate cancer. Brachytherapy is one of the most commonly chosen modality because it's so minimally invasive and has an excellent cure rate, the same cure rate as even using the Da Vinci robotic prostatectomy. So I'm sorry you went through what you went through, but we always have to look at what does someone go through in their life. Nurses have one of the most difficult jobs imaginable. There's some unruly patients as well that are very vulgar and disgusting, and nurses are overworked. They're not paid well. There are times where there's shortages where you got one nurse trying to deal with 2 wards at once. So please give them a little leeway. They do their best, and for the most part, they are the guardian angels of our medical fraternity and Princess Margaret. We have another call coming in. This is Urologist Speaks.
Good evening, Dr. Pinto, and good evening to our transplant doctor. I didn't remember his name. Can you repeat his name for me?
Government High graduate, Dr. Vantario Taylor.
Oh, Dr. Taylor, right. And he did mention that Mr. Pinto was his teacher, and that is so nice.
That is correct.
Yes.
I have a few questions here, right? But I know you don't have the time, right? Is kidney transplant going to be a regular feature now at PMH?
We expect it to be. We did the first of hopefully many last week, and it's our expectation that we're just waiting for the government to give us the budget to let everyone that is eligible be evaluated and move forward. It's our hope that we do a few more before the end of the year, and then that opens the door for everybody who is eligible, like I say, to be evaluated. You come and you're evaluated, you bring your donor, and your donor is evaluated, and everybody who is a good match and a good fit can be considered for a transplant.
Is there an ethics team that decides on eligibility?
Yes, well, the ethics team really is there. It's an independent body of lay people that is not associated with the Princess Margaret Hospital or the Public Health Authority, that reviews those people that are medically fit and that have already gone through psychiatric evaluation, social work evaluation, and they've jumped through all the hoops, and that the doctors think that are fit for transplant, then they go on to be reviewed by an independent body, an independent ethics review board, so to speak.
And how often do you think we could have kidney transplant being done once everything gets going?
Well, it's our hope that maybe we can do a transplant every couple of months or so. Every 2 months, every 3 months, we could do a few. That would be what we'd start off with. That would be a good transplant program.
Yeah, but like with anything, you need to maintain your skill. You can't just go lay dormant for 2-3 months, or much less 2-3 years. So the more you do, It's not just one transplant surgeon, it's a team. And you have to work as a team. And the more we do, the more
people we're able to get off of dialysis, and the more we're able to save the government and to put our young people back to places of productivity and I guess living their best life, as you say.
Excellent discussion, doctors. I really enjoyed the show.
Thank you for your call. So to answer the previous caller's question in terms of trying to screen for prostate cancer, prostate cancer is the number one cancer in this country, far exceeding breast cancer, where as many as 1 in 6, 1 in 7 men are going to develop prostate cancer in their lifetime. Putting it a little bit more in perspective, every man, if they live to the ripe old age of 80-something, are going to have some element of prostate cancer. So the vast majority of men who reach old age are going to die with prostate cancer, not from prostate cancer. But because we have all the risk factors for prostate cancer, including being of African ancestry, we have more aggressive form of the disease that afflicts us 6 or 7 years before our other racial counterparts, we have to be very diligent and pick up prostate cancer. That means doing a PSA blood test at a bare minimum every single year from the age of 40 up to the age of 70, even up to the age of 75 or beyond. But if your PSA is elevated, it doesn't necessarily mean anything because there's so many reasons for your PSA being elevated. It means you may have inflammation of the prostate, infection of the prostate in the form of prostatitis. You can have a very large but benign prostate that can lead to a contribution of your PSA being elevated. You can have incomplete bladder emptying. All those things can contribute. So the gold standard is to do an MRI, ideally a 3T MRI, plain and contrasted scan that doesn't involve any radiation of not just your prostate, of your pelvis. Or if available, you can do a PSMA PET CT scan as well. Both of them are the gold standards in terms of determining whether you need to do a biopsy to get a tissue diagnosis or not. So PSA is just the first line in terms of screening. You do more specific investigations once the PSA is elevated. So we had a very interesting talk. We have a lot more to talk about. I want you to come back, Vantario, and you've done the Bahamas proud and continue to do great things. You're a government high school graduate, and I think a lot of persons can, particularly young men, can be inspired by that and continue to do great things and reach for the stars. I support you, and I'm sure many Bahamians do. Have a good evening.
Thank you so much. It was a pleasure being here.
Thank you again. Good night, Bahamas.
Rise up again. Let nothing keep you down. Live your best.